Good morning or good afternoon, depending on your geography. My name is Chris Cronin. I work at Moby. I'm the CEO of our employer space, and we appreciate you joining the next webinar in our series, Advancing Health Equity in Your Organization. We have a wonderful panel. I am certain we're going to have a rich discussion on a really important topic today. Before we get to that discussion, a few housekeeping items. If you have questions, comments, reactions, we'd love for you to participate in this discussion. Enter them into the Q&A section within the Zoom meeting. Secondly, we will record this. We'll send a link out after the discussion. So look forward to that coming through as well. With that, I want to welcome our panelists to the discussion. So Anjoli, Pahoua, and Pearl, welcome to the webinar.
Hi, Chris. Good to be with you.
How are you?
Great. Good morning.
Thank you.
Good. Let's start with some introductions. Anjoli, I'll let you kick us off.
Sure. Thanks, Chris. I'm Anjoli. I'm the Director of Diversity, Equity, and Inclusion and Program Outcomes at Moby. A little bit about Moby. We are a health outcomes company, and we improve health by providing a high-touch, one-to-one coaching program focused on lifestyle, emotional health, and medication management. Using advanced analytics, we are able to identify populations where we can make a real difference, both in individuals' health status and expense reduction for our clients.
Thanks, Anjoli. We look forward to hearing from you. Pahoua, welcome.
You're welcome. Thank you, Chris. And thanks to Moby for bringing all of us together. Good morning, good afternoon. Like Chris said, my name is Pahoua Yang Hoffman. I'm the Senior Vice President for Government and Community Relations at Health Partners. And at Health Partners, we're an integrated healthcare organization. So we're both a care provider of services and also a provider of health plan coverage. And one of the reasons why I'm really honored to work for this organization is that it is consumer governed. So our patients and our members are the ones who elect our board members, who themselves are patients and members. So really excited to be here today.
That's great, Pahoua. We're excited that you're here as well. Pearl, welcome.
Thank you. I'm very happy to be here. My name is Pearl Isawumi. I am Senior Insights Account Manager at Unite Us. A little bit about Unite Us. Unite Us is a technology company that builds coordinated care networks of health and social service providers. We enhance the traditional healthcare network with community collaboration supported by our community engagement teams. And we provide the infrastructure and platform for healthcare organizations and communities to partner in addressing social determinants of health and advancing health equity. In my role, I work with our customers to support them in applying our social needs data and analytic solutions to identify emerging social needs in their population and develop strategies to make the greatest impact on their population and then measure the impact of those strategies implemented. I'm very excited to be part of this panel. Thank you.
Thank you, Pearl.
Hey, Chris, can I jump back in? Because I forgot to talk about my role and how it relates to our topic today.
That seems appropriate. Please put
So related to our topic today, in my role as the lead for government and community relations, I get to work with our internal and external partners on trying to make healthcare more simple and affordable. And one way to do that is through health equity. So again, I'm really glad that we're talking about this topic today.
Perfect. I'm glad we're talking about it as well. Each of you brings an expertise and experience that will be really important as we venture into this discussion. This is a topic that appropriately so has gotten a lot of attention. There's a lot of different language and vernacular that's used around this topic. I'm sure a lot of it will come up as we go into the discussion today. Anjoli, can you help level set some of the definitions and some of the language that will likely come out of the discussion today?
Definitely, Chris. It's very important that we are all talking the same language when it comes to health equity, and then we all have common terms and definitions for what we're working towards. So let's start with, what is health equity? It really means that everybody has a fair opportunity to attain their full health potential, and that no one is disadvantaged from achieving that potential due to social circumstances. And when health equity is not being achieved, we see gaps in health outcomes between various populations. Those disparities that are seen are unjust and can be addressed. So that leads us into our next term that I want to talk about today, social determinants of health. As I go into this term, one thing I want to mention is that social determinants of health and health equity are not the same thing, even though sometimes today we do hear the terms being used interchangeably. Addressing and recognizing social determinants of health are a very important component of health equity. But let's talk about social determinants specifically. They are the conditions in which we live, work, learn, play, age. It basically is a lot about our community. And another thing I'll mention, another caveat here, is that social determinants of health, they're not good or bad. We all have social determinants of health, and sometimes they're often framed up in a negative frame today. But let's actually, one example I want to give, let's take an example of somebody who has obtained a higher level of education. They start a new medication. I'm going to give that example, Chris, because I'm a pharmacist by training. They start a new medication and they are noticing, hey, I have this side effect that I didn't have before. They may have educational knowledge, skills, and background to realize, I think this side effect is coming from an interaction with one of my other medications, and go have an in-depth conversation with their doctor about that because they have a higher degree of health literacy and they're able to do that. So that's an example where social determinant actually helps somebody out, their educational background. Let's talk about the 5 key areas of social determinants of health. That's healthcare access and quality, education access and quality, social and community context, economic stability, neighborhood, and built environment. And when folks are left vulnerable or disadvantaged, or there's disproportionate resource allocation, that actually is where we start to see these social determinants of health turn into risk factors, or social determinants of health risk factors, as we call them. And this could be things like housing instability, lack of access to transportation, racism, discrimination, violence, lack of job opportunities. People may live in food deserts where they do not have access to the nutritious foods that they need. There could be pollution in their community, etc. So these are where we see the areas, the 5 key areas of social determinants of health. When people are lacking in those areas, they do become social determinants of health risk factors. I also want to talk about how much these social determinants of health actually impact our health outcomes or health status. This is called what we call the 80-20 model. You can see that our health outcomes here, our health status is actually 80% due to socioeconomic factors, our physical environment, and health behaviors, all of which are impacted by social determinants of health. It's actually only 20% of health outcomes and health status that are influenced by healthcare itself, the healthcare system, our providers, the care that they provide, diagnostics, procedures. Really, most of our health and outcomes and status are influenced by what you see, the 40, 10, and 30, those socioeconomic factors, physical environment, and health behaviors. Now, at Pahoua, I know at Health Partners, you've seen this 80-20 model of health really play out. Could you tell us a little bit more about that?
I sure can, and I'm sure that we've all seen iterations of that graphic before. Sometimes it's in an iceberg model or in the way that you just showed us today, Anjoli. And that's why I have a job. And that's why in my introduction, I talked about getting to work with internal folks at Health Partners and external folks through my role working with community. Because as Anjoli just pointed out, so much of the change that we can make to help improve health and well-being for our community really lies outside of our healthcare setting, right? Outside of our clinics, outside of our hospital setting. And so that's the fun that I get to work on, which is how do I help our organization and our community think about their health and well-being? So certainly we want to make sure that our patients and members, when they arrive at our clinics and hospital, have a great experience in our clinics and facilities. But we know that there's so much more that we can do outside of our clinical setting. So that's why I get to work with stakeholders to think about ways that we can push out information and resources to our patient and members. And that's why I'm looking at Pearl Space, because Unite Us has a great platform where we can really push out and customize information to our patients and members through their platform so that they can get information that they need customized to their zip code 24/7. So I really look at that as a personal level intervention to make sure that they have the information that they need. But we know that not everybody goes to an app or a platform. And so we want to make sure at Health Partners that we work with trusted community-based organizations whom our patients and members already have a relationship with. And so Anjoli talked about some social determinants of health. So for example, at Health Partners, we know that we have patients and members who are food insecure. And so we want to make sure that we are partnering with organizations who deliver access to food or who provide mobile food trucks, who actually go into the neighborhoods where there might be some food deserts. And so everything that we do at Health Partners when it comes to partnership is informed by the information that we have collected through our health needs assessment, or collected through those forms that we know all of you fill out when you go visit your doctor, those first 15 minutes when you're filling out your paperwork. All of that tells us the needs of our patients and members. And then on the government affairs side of my job, I get to work at a systems level too, right? So given the data that we have, given the information that we have coming through our patients and members, and also the data that soon you'll hear from Pearl, we know that there are systematic things that we need to change to really have a much more impact scale-wise on the community we're all trying to serve.
Thank you, Pahoua. I really appreciate that, teeing it up there. This is where, Unite Us really comes in. Like, we focus on helping healthcare organizations such as health plan, providers like Health Partners, government agencies to understand the lives of their patients and members in the community, and how the socioeconomic conditions, examples that Anjoli had mentioned, like housing instability, food insecurity, transportation needs, drive impact on health and health outcomes, so that we can anticipate and target their needs and provide timely resources and support to maintain their well-being before costly healthcare events. And I want to talk a little bit about, in that regard, our partnership with Health Partners. Unite Us collaborated with Health Partners to support the provision of customized resource lists for patients after each visit through our network platform, in order to resolve the social needs identified through screening by providers at Health Partners. In addition, Health Partners also provided public access to our network of community-based organizations to allow individuals self-serve for themselves, so they could search for resources to meet their specific needs. We know that people who have challenges with socioeconomic needs, sometimes they just need to know where they can find the right resources to meet their specific needs. This is why collaboration across organizations is so important, to help people access the resources that they need and get them all of the information to meet their specific needs.
Yeah, Pearl, that's so true. None of us can address health equity alone. It really takes partnership between organizations, and that's why you see the three of us today from very different organizations working together. And Moby actually also had an opportunity to partner with Unite Us and apply their predictive models. So Unite Us has predictive models which estimate these social risk factors related to social determinants of health in our specific population for Moby's participants. And we're able to identify what those social needs are and design more informed solutions to address those risk factors, and really focus on that whole person approach that Moby carries out in an even better way. Another valuable piece of data that Unite Us is able to provide is racial and ethnic demographic data, as well as language data. This allows us to disaggregate our outcomes. So when we're looking at engagement, retention, or maybe clinical metrics like blood glucose or A1C for participants with diabetes, or core metrics like weight or hours of sleep, we're able to see if different populations are having different results in those areas. And then we're able to specifically address disparities that we see. And that's because of that ability to disaggregate the data. There's one specific example I want to mention with our Hispanic Latino population. So we disaggregated our engagement results, and we saw that our Black population had a higher engagement rate while our Hispanic Latino population had a lower engagement rate. So what we did is we started to translate more of our campaign materials, and not a one-for-one translation, but really culturally relevant translation that would help us connect to our Hispanic Latino community. We got together a group of Spanish-speaking employees who analyzed the Spanish-speaking participant journey with MOBI, and we were able to leverage their expertise to improve that journey and ultimately engage more Hispanic Latino participants. So this is the type of very specific information at a subpopulation level that we're able to disaggregate. And really, I mean, health equity is not just for minoritized or underrepresented populations, because when we find solutions for one population, it helps the overall population and the overall results. So it's been a great experience and partnership between MOBI and Unite Us in applying those predictive models.
I'm so glad to hear you talk about disaggregation of data, Anjoli, as someone who is a Hmong person, and I'm often in the Asian category. And that Asian category, just like the Hispanic Latino category, is very broad, right? It's encompassing of many different ethnic groups, and we all have different experiences. So I'm just really glad that you're looking at that disaggregation of data and really drilling down to find out more.
Yes, and you make a great point, Pahoua. Sometimes we cannot look at these broad categories. We have to get even more specific. I know recently, different organizations looking at COVID-19 vaccination rates found that when they looked at the Asian population, results looked okay. It looked like they were getting vaccinated close to the average of the rest of the population. But when they actually disaggregated out the results further into Hmong, South Indian, Vietnamese, etc., we started to see the disparities pop up. And also when looking at the Black population, looking at African-born and US-born, we also see differences in results there. So it's very important to be specific in how we disaggregate. Another thing I want to mention is it's often important to start with disaggregating with racial data. Disaggregating by other factors, socioeconomic status, gender identity, sexual orientation, also very important. And you may want to look at your population and determine what's important for your organization in terms of disaggregation. But we know that racial disparities are where we see huge gaps, and they're urgent to address in society. So it's often a good place to start.
I'm glad you all agree that data is so important to all of this work. And this is why, Unite Us and our collaboration with several partners in different aspects of the industry is very important. Unite Us uses one of the most comprehensive social determinants of health data sets that is at the foundation of our technology and care collaboration platform. The Unite Us social needs system is our social determinants of health taxonomy that predicts and classifies socioeconomic needs to help identify, measure, and quantify social barriers and circumstances in which people live at the individual level. So the social needs system really supports a more data-driven approach to care management program design and really investment prioritization and integration of health and social care, leading to better outcomes and experiences for patients and members across the country. Based on our experience with different customer types in the industry, we know that organizations use tools like the social needs system to establish benchmarks and baselines in their population, identify key opportunities for improvement, and measure the impact of interventions on their population. I'll just kind of call out some of we as an organization continue to learn and evolve with the industry as we receive feedback from our customers, and as also regulatory requirements continue to drive change in health equity. So one example of such change, and Anjoli kind of touched on this a little bit, is how we're well positioned to support the recent NCQA HEDIS measurement requirements for the year 2023, which one of them specifically talks about that race and ethnicity stratification being added to 8 additional HEDIS measures, and with the plan to integrate this stratification into additional measures over the next several years. In addition, new social needs screening and intervention measures have been added to the HEDIS to encourage plans to address and assess members' unmet food, housing, and transportation needs using specific screening, pre-specified screening instruments. And so this is how all of these changes reflect the importance of defining and tracking metrics in order to better understand where disparities exist. You can't really change what you don't measure. And this is something that Unite Us has significant experience in through our work with several organizations to report on different metrics using our different solutions. We partnered with Mobi, and I know Anjoli also mentioned this, specifically around providing data to help them identify and define key strategies around health equity. Using our Unite Us broad data to complement Mobi's data, offered a new dimension of insights that was used to inform new strategies. Mobi applied these strategies to create personalized health solutions for their participants in each segment of their population. So we're talking specific racial groups, specific racial categories. And we recently published a case study that highlights the value of this engagement and how it really helped to drive health equity within Mobi.
Yeah, Pearl, real quickly, if I can jump in, I will say, we started on that work with one hypothesis or idea and thought, and we actually learned an entirely different set of things. We thought we would identify some real opportunities to refine our program and things that we're not doing well, and certainly we did that. And we also identified some things that we are doing well and we should do more of. So it was a really interesting and helpful experience for us to go through.
I'm glad to hear that, and I'm sure our team is very excited about that.
Yeah, one thing that we noticed when we applied the predictive social determinants of health models and looked for disparities is oftentimes you'll see one group who's doing the best. We call that our reference group. And then you might see another group who's close to that reference point. And you're like, okay, maybe if we could just do a little bit more for that group who's really close to the reference point, that would be great. But actually, that's kind of a trap. Because if you start to try to resolve those small wins first and you don't start with the biggest gaps first, what may end up happening is that you try to apply the same solutions for the group that only had a small gap to a group that has a larger gap. And you'll find that those solutions don't work. And one thing that we've been finding in this work, health equity work and resolving disparities, it's all about tailored solutions, being very specific and community informed. And Pahoua, I know that is really your bread and butter. So I'd love to hear more from you about community engagement.
Absolutely. So this would be a good time for me to just kind of tell everybody. I keep talking about the fun I get to have at Health Partners, and part of the fun is I come into my role without any healthcare background. And that was by design so that I can really be in this new environment with a beginner's mind, right? With an outsider's view. And so I've done a lot of community engagement work in my previous role, but not in healthcare. And so I'm really trying to bring some fresh eyes and hopefully some fresh thinking into what we could be doing better as a healthcare provider and as a healthcare plan. And so thanks for the invitation, Anjoli. So what I will say, what we have started to do at Health Partners. And so some of this work preceded my time as well. So they should absolutely get credit for doing this before I arrived. But I would say any work that you want to do in terms of advancing health equity, and some examples were given already today, it really starts with us inside that organization, right? What are we going to do that is different? And so at Health Partners, we've been rolling out training for our workforce. So this is frontline staff, this is administrative staff, this is clinical staff. It's team members like me who actually don't work in a clinical setting, but all of us have a role to play. And so we have 2 trainings that I want to lift up for everyone that I think could be adapted to your organization. One, we call the Inclusive Leadership Series. So this is a cohort style workshop series for leaders to think about how we can better incorporate diversity, equity, inclusion into our work. So again, no matter where you sit at the organization, we want you to sign up for this. And in fact, people are signing up. And in fact, there's a wait list because it's a cohort model. The other training that I want to lift up that Health Partners is doing is unconscious bias training series. And so we know that no matter how evolved you may think you are, we all bring some bias to our work, right? Some bias to the conversations we're having. And so this unconscious bias training is really targeted to help individuals at Health Partners understand what bias is, how it shows up, recognize again that everyone has bias. And in particular, we have a clinicians track. So when you think about Health Partners, people often think about our clinicians, our doctors, et cetera. And so we have a tailored curriculum just for our clinicians. Again, on recognizing and preventing unconscious bias and showing up in our patient care. So it defines the role of bias, the importance of having culture humility. Anjoli mentioned social determinants of health. And already we're seeing a report in increase in health equity by reducing health disparities in areas such as asthma, breast cancer screening, colorectal cancer screening, and child immunization. And if I have time, I'm just gonna tell you another example. Maternal morbidity and mortality remains high among Black mothers. And so this is not anything new. In fact, it's been one of these entrenched issues that we're all trying to figure out ways to mitigate. Our clinicians actually did a patient journey mapping. Like what happens? So to fully kind of understand and to have more compassion for our patients, we mapped this journey, and our patients and our clinicians now better understand kind of that patient's experience. And so using that information along with information that Pearl mentioned that we have externally, how can we create a better experience for our Black mothers who come into our birth center? So just lifting that up as an example of the things that we are doing at Health Partners to advance health equity.
That's
Thank
great.
you.
Hey, but one question I'll ask Pearl or Anjali, you guys to jump in as well. You talked about a beginner's mind. You talked about training. As organizations are thinking about getting started, and building a strong DE&I program, how do they start? What are some of the things they should be thinking about? Pahoua, certainly the trainings you mentioned is very helpful.
And can I throw in one question? I'm just going to cheat and say, why? Why do we do this, right? Besides it being a good thing to do, why is it important?
Sure, that's a great question.
Yeah, go ahead, Pearl.
Yes, I want to start with the why. It's really, it is the right thing to do, but also it's the public health mindset. It's the mindset that when you fix a system for a subset of a population, you fix it for the whole system, right? So when you solve the problem for a small group of people, that impacts the whole population as a whole. It's kind of that when you think about the concept of herd immunity and how that improves the health of an overall population. So that's the concept and that's the mindset as I think about why do we need to do this. But again, helping organizations get started. I think as I think about how to get them started, one of the things, and I can't say this enough, is understanding your population. And that only comes, that comes through the use of data, through understanding the specific needs of your population without making any broad assumptions about certain groups or certain populations. You need to know what the data is telling you about those populations. And then the next step is, what do you do about it? How do you take action on the information? Partnering with other organizations to take action is key to driving sustained change. And so this is why, I gave those examples about our work with health partners and our work with MOBI, really to support some of these interventions and really drive action and drive change. Specifically, we also talk about how, our information can support, our data can support self-insured employers. For example, they can use our analytic solutions to identify socioeconomic needs of their employees and start to think about programs and services that they can offer their employees to meet the needs that were identified. Our solutions support very targeted care management and outreach efforts, and our data really makes these efforts actionable. So, if I were to call it in a step-by-step process, it's understand your population, take action on the information, collaborate within the community, and then, the whole feedback loop thing is finally monitor in real time the impact that your interventions are making on the population and continue to improve and make changes on those interventions that you're doing as you continue to use the data to inform your strategies. That's how I think that we can start to make a change system-wide across the whole population.
Yeah, Pearl, I think you hit on some really key strategies. Another area I want to mention for getting started, it's really important to help your organization understand that health equity is not separate from the organization's existing goals. And we have to embed a health equity mindset into the specific actions that we're taking as an organization to really lift up those populations that are experiencing disparities. But as Pearl mentioned, the entirety of our population, the entirety of the growth of our companies, and health equity, when we can address that, it's going to help us meet goals that we already have set for things like engagement, retention, clinical outcomes, or meeting CMS STARS ratings and those types of goals that we already have. So thinking about how we see those goals through a health equity lens and mindset is really important. And MOBI, similarly to Health Partners, started our health equity journey with really starting at diversity, equity, and inclusion. And with that, we also did a comprehensive unconscious bias curriculum. We are following that up with trainings on microaggressions, stereotyping, and more. And each function at our company has committed to specific actions that they will take to mitigate implicit bias in their work, whether that's thinking about using more diverse images that connect with various populations, writing culturally relevant recipes. There's tons of examples of how we can mitigate bias that we all have and all bring to our work. We also support minority-owned businesses. It's very important to create more economic stability and prosperity in our communities. And one of the ways that MOBI does that is by investing in vendor diversity and tracking that very diligently. Additionally, we have efforts around recruiting and hiring and increasing diversity in our workforce. The more perspectives that are from these different populations that we're serving, the more that we can have that within our organization, the richer our programs are going to be, the richer our company culture is going to be. And so we invest a lot of time in this. And so one point I want to make here is that diversity, equity, and inclusion efforts tailored towards employees cannot be separated from health equity. They're so connected. And Pahoua, I know that at Health Partners, you have sort of this health equity framework to help your leaders see through when they're making decisions or starting new initiatives. I'm wondering, and MOBI actually has something similar, but I'm wondering if you could tell us about the framework at Health Partners.
Absolutely. And I do want to get back to your comment about increasing your vendor pool because we have a great strategy to that that's more external facing. But I mentioned the 2 trainings, and those are, we encourage our team members to sign up for those. But we also realize, and this is, I think, true of every organization I work for, sometimes it's hard for our team members to know, like, how can I contribute to equity, to advancing health equity? Like, what is my role? What can I do? So if someone is sitting in finance or legal who may not have the title such as you, Anjoli, like, how can they see themselves in that role as well? And so at Health Partners, we just rolled out what we call a health equity or an equity framework. And it has just 3 simple questions that we ask each of our team members to think about when they are about to maybe launch an initiative or put together a new policy for the organization. And so I'm just going to read it to you so that I don't get it wrong here by memory. But again, these are, I think, could be easily adapted for any organization. So, and because we're healthcare, and because I mentioned this during my introduction, our first question is, for whom is this process, policy, or change simple and affordable? So we're constantly thinking about that. But for your organization, you might tailor that question to something that's more relevant. The second question is there any group or population negatively impacted or left out by this process, policy, or change, and how? Again, so allowing us to kind of step back from that work at hand and say, okay, whom are we might be leaving behind inadvertently? And going back to the bias training, what might I not be thinking about right now? Or how might I be projecting my own experience into this work that we're about to do? And then lastly, what potential changes could you make to increase or improve equity and inclusion? And so we ask this of all of our team members, again, no matter where they sit in the organization, we know that we all have a role to play. So the trainings and this equity framework is really what we're starting to do inside. So change really begins with us internally, and because it's going to affect the way that we show up. But I'm going to jump off of what Anjoli just said a little while ago about vendor. We're doing that too in our various sites, but the example I want to give is Regions Hospital, which is situated in downtown St. Paul. We have put together a concerted effort, that we call our St. Paul strategy. So how are we better connecting with our neighbors, with our partners who actually are in the same footprint where we provide services? So we took a look at the small businesses around Regions Hospital and said, how can we better partner with them? And this was very acute right after the unrest that followed George Floyd, when many of those businesses were starting to rebuild. So we looked internally and said, what are we good at? We're good at running a business. We're good at having kind of buying power with our supplies. Can we share that with our small business owners who are in this part of the city, are business owners of color? And so we've extended our knowledge, our skill set, our relationships to those partners in our community that really don't have anything to do with healthcare. But again, that 80-20, what are we doing to help support our neighbors so that they might be more economically stable, might have more of the technical skills that we have, so that they can improve their own health and well-being outside of our clinical setting. So I wanted to lift that up as another example of the ways that we're advancing health equity, not only in our clinical settings, but also in the community.
Yeah, absolutely. Thank you for those really illustrative examples, Pahoua. And one thing I want to mention is, as you hear Pearl, Pahoua, and I talk, it's no coincidence that how we started stories and our diversity, equity, and inclusion strategies align. These are key areas to focus on in terms of employee education on unconscious bias and related diversity, equity, and inclusion topics, vendor diversity, recruiting and hiring, and then application of disaggregating data and outcomes, as Pearl has been mentioning. So really, you can see the themes emerge, I hope, as we all talk, and they are quite aligned.
Yeah, there's one thing I'll add a little bit around that. We know that certain populations in the country, struggle or don't really access traditional healthcare system for various reasons. So like certain populations have a mistrust of the healthcare system. And we know that that exists within certain communities. This is where, continued collaboration and our network specifically allows the opportunity for these populations to get services through trusted resources within their own community that would meet their specific needs. It's really about starting to build that trust in the system and using that to then get people connected to the right care, to the right resources, so people can actually start to utilize the healthcare systems in the way that we would expect them to. But until we use, grassroots resources to rebuild that trust in some of these communities, it's constantly a struggle. And so that's why a lot of all these efforts around, funding businesses, local businesses and things like that, it is really all about building that trust in the system.
So I've got a question on that. Maybe Pahoua, I'll direct it at you and the others can comment as well. We've talked a lot about community. Pearl, you just talked about within some populations, there's some mistrust. Anjoli, you talked about diverse vendor selection. How does an organization think about creating some relationships and building some relationships with outside organizations that can help with some of these issues or help think about addressing some social determinants? If I'm an organization, how do I think about what's the first step I take? You mentioned your St. Paul strategy, Pahoua. Anjali, I know a bit of our story and how we identified some partners to help us think about some things, but do you guys have thoughts on that?
Yeah, I'll chime in and then I'll see what Pearl and Anjali have to say. I mentioned a while back about how the partnerships that we pursue and strategies that we pursue are really community informed, so that they're coming through our community health needs assessments and other assessments that we have. And we see it, since we have access to that information, we see it as our responsibility to share it with our community partners too, right? So I've just been doing this in my first 7 months on the job, is really sharing that information with our partners, saying, I'll call up Open Arms, who provides medically tailored meals, and saying, hey, here's what we learned about our patients and members. We know that many of our discharged patients are food insecure. This is what you do. You provide medically tailored meals for people who are discharged after a serious illness. Can I share my data with you? And can you tell me what you're doing? And how can we partner together to really create this deeper continuation of care, so that as they leave our facility, you come in and provide those services that they might need at home. And so I would say, start with the information you have. What is it that you are trying to solve for? What do you know? How might others benefit from the knowledge that you have, from the data that you have? Because it's this data sharing that I think is going to get us further. To Anjali's point earlier, none of us can do this work alone. And so I think it's that first call to make based on what you know about the community members you're serving, the clients that you're serving, the employees that you're trying to serve.
Perfect. I saw Pearl smile. You like Pearl smiled when data was mentioned. Go ahead, Pearl. And then I think we'll move to questions. So I'd ask participants, if you have a question, please populate it in the Q&A. I know we have a few there, but Pearl, please.
Yes. Our Unidos network of community-based organizations really supports our customers in helping them identify where, so not just identify the needs that within their population, but also what organizations or service resources could meet those needs. And that starts to give them insights as to which organizations potentially they can start to develop some partnership with. Within our platform, we're able to help the organizations kind of, not just help our customers identify these organizations, but then understand how to potentially develop opportunities for improvement and make decisions regarding program design and investment allocation into those partnerships, because those partnerships are really an investment thing. You have to make a conscious organizational decision to invest in those partnerships. They take time, they take effort, and they do take money. It really has to be a conscious effort, and we really support that.
Wonderful. Thank you, Pearl. We have a number of questions coming in, so I'm going to point them a certain direction, but feel free, each of you, I'm sure, has a perspective on it. The first one I'm going to start with is around when thinking about the reference group in quality measures by race and ethnicity, do you recommend using the highest performing group, the average, or white, even if not the highest performing, and why? Anjoli, you talked a little bit about gap, small gap, large gap. Do you have a perspective on this question?
Yes, and I'll mention I rely on a lot of research and theory published by the Institute for Healthcare Improvement. They are some of the worldwide renowned experts in health equity, and the going thought is to always use the highest performing group. Why? Because if that group has the potential to achieve those results, so do other populations. And we have to do more for those other populations, design additional solutions, tailor our current solutions, bring in the community to inform our efforts to bring everybody up to that highest performing group, which we call the reference group. So I do always recommend comparing to that group, no matter what their racial ethnic background is or socioeconomic status. You do compare to that highest performing group and ask yourself, why is that group performing the highest, and how can I bring everybody else up to those same outcomes?
Thank you, Anjoli. I appreciate that. We got a question here. Pahoua, I would like to hear your perspective on how do you deal with individual employees in your institutions who just don't want anything to do with DE&I work and the issues that work tries to improve?
Ooh, that's a really good question. So I'm going to borrow what Pearl said a while ago about how you can't change what you don't measure. So I will say, unless one way to motivate, I think, employees and team members who might be reluctant to participate in DE&I activities is first, after you've already given them the opportunity to learn through trainings, right? So we talked a little bit about that, and we talked about the framework. I think it has to absolutely show up in their performance evaluation. Because if you can't measure it, it's not going to happen, right? So I think it absolutely has to be tied, and this is at all levels, right? From the CEO to various levels, it's got to show up in your performance evaluation. Otherwise, it's this thing that we kind of just do, but we really don't invest in, right? And personally invest in. And so I think making sure that our employees know the importance of this work. So to the why that Pearl mentioned earlier, and for health partners, the why is this is our future. These are our future members and patients. We know that with changing demographics, these are the folks we're going to be continuing to serve. So how do we get better today in order to better serve a changing population? So making clear on the why, giving them the what and how we expect you to roll this out into your work, and how we would like you to think about the role that you have. And then I think lastly, it's got to show up in your performance evaluation so that they can see a link to what they might try and get credit for it if they are in fact doing it. So that's a measurement that I think needs to exist to really move everybody in the same direction.
Yeah, really key points, Pahoua. If I could just add on to that for 2 seconds here. Managers are key, and their team needs to evaluate the inclusivity and the diversity mindset on that team and be given the opportunity to do so in those reviews. Moby has an employee competency called Learning Across Differences. That's all about measuring DE&I results and investment from various employees.
Wonderful. Thank you. I think we have time for a couple of more, and there are a couple of more questions in there. If there are other things on folks' mind, I would encourage them to put it in the Q&A. We'll take as many as we can. This question states, what role, Pearl, I'd love your perspective on this. What role does the research community play in health equity and providing evidence-based guidelines and interventions that respect and represent the unique anatomy and physiology of different races and ethnicities to support positive health outcomes? Historically, research has been conducted on well-educated Caucasian individuals. So a lot in that question, but I'd love your perspective on it.
Yeah, that's a really loaded question, but a very good one. And, understand this really plays into kind of historical mistrust in the system and how that has impacted traditional research around different racial and ethnic groups, because they've typically not been included in research on a broad scale. And so as health equity becomes a bigger topic across the industry, there's been more and more focus on inclusivity of minority racial and ethnic groups into specific research to better understand their own unique challenges and how those impact how they access healthcare system and how their health outcomes are impacted by research results that don't include them. There's a lot of organizations now that are specifically investing in recruiting minority populations in research. This is how we start to gain a handle on health equity and really understand breaking down these differences between different racial and ethnic groups. It's really about inclusivity, encouraging people and building the trust. If they don't trust you, they're not going to want to be involved in any research, right? But once you start to build that trust, then they start to feel like, okay, maybe this is, I can get more involved in some of these research. And then we start to understand from the data out of the research.
Yeah, Pearl, thank you so much for those important insights. What I also want to add is that historically in medicine, there have been some calculations which use racial factors in them, such as kidney calculations or asthma calculations. And we are starting to gain more insights and learnings to whether or not it's appropriate to be applying those racial factors into those calculations or not. And so I think as in the near future, you'll see guidance coming out on that may correct how we've been approaching some of these disease state specific calculations. And then the other piece I'll mention is training health professionals. We see more diversity in images. I think one example that's come to light in the past couple of years is that in dermatology, providers had only been seeing skin conditions on white skin and didn't necessarily have the exposure to identify those conditions in people of color with darker skin tones. And so this evolution that we're seeing in medical education, research, and how we approach our patients and serve diverse populations, I think is going to bring us a long way in health equity as we continue this important work.
That's wonderful. We've got time for one more. We'll sneak one last question in. What role does personalized medicine play in social determinants of health, if any? For example, being able to predict a health path that a member is on and trying to intervene prior to a bad outcome.
Oh, Chris, I think this gives me a great opportunity to jump in with something that I didn't know whether I would have the opportunity to insert into our conversation. So this is speaking from a non-clinician. I'm just really excited about Health Partners My Genetics initiative. So this is a community health research program where we're taking a look, we're asking individuals to submit to be a part of this research, where the hope is that your DNA tells you a lot of things, right? We know this. And so this study looks at what your DNA could tell you about your health. And the hope is that the knowledge we will gain will be used to provide more personalized care to our patients, families, and the community. And so this might not be exactly what the person who was asking the question was thinking about in terms of an answer, but I think that this does get to more personalized care and hopefully more personalized medicine in order to, again, get ahead of those negative outcomes.
Yeah, that's so true, Pahoua. And one thing I'll add is that predictive models are very important in looking at our entire population and identifying needs, but information directly from the participant on their circumstances, on what they're experiencing, must be coupled with that predictive information and those predictive models to truly meet needs and tailor our program. So I think it's that combination of predictive models and that community informed voice directly from our participants that are really going to move the needle.
That's great. Well, thank you, Pearl, Pahoua, Anjoli, for this discussion. I personally took a bunch of notes. I learned a bunch of things. I'm sure our participants did as well. Thank you to our participants for taking the time to join. As I mentioned, we will send out a link to this webinar. I had a bunch of takeaways. Some of them, it all starts, all of us have a role to play. It starts with us. What's the bottom line? Pahoua, you asked that question. Hold on, I want to ask why. When the question came up about the reluctant employees, that was one of the things I heard from you, is start with the why it's important. I think that's really important. And then we talked a lot about data disaggregation, and having data informed approaches to this, amongst many other things. So it was a rich discussion. I appreciate the panelists leading us through it. And for all those that participated, thank you for taking the time. Enjoy the day.
Thank you, Chris.
Thank you.
Thanks.